So I'm Danielle Prati. I'm the Vice President for Quality and Research with ElevatingHOME, and I am very excited to introduce this next session. We're going to start our conversation this morning about quality and research with Dr. Stephen Strongwater. Dr. Strongwater is the President and CEO of Atrius Health and VNA Care. He's been there since August of 2015. He's responsible for all aspects of leading the nonprofit accountable care organization that includes almost 7,000 employees and serves over 675,000 patients across eastern Massachusetts. They provide coordinated medical care, home health, and hospice. The Atrius Health practices include numerous sites in Dedham, Granite Medical Group, Harvard Vanguard Medical Associates, and the VNA Network Care Foundation. Previous to this, Dr. Strongwater served as the Geisinger Health System's Chief Transformation Officer and provided leadership for transformation through implementing new models of care and developing strategies and tactics to improve quality, patient experience, and value, while leveraging analytics and simulation models to improve care. He served on several regional and national boards and currently serves on the Massachusetts Digital Health Council, the IBM Watson Advisory Board, Janssen Healthcare Innovators Council, and the Healthcare Executive Networks. Please join me in welcoming him to the stage.
Thank you very much. Good morning, everybody. And thank you for everybody who's watching as we stream online. I am so excited to be here with all of you. I believe you are the secret weapon to save our country's healthcare system. Are you with me? So today I want to share a little bit about what we do. Massachusetts is a different country, I understand that. But we also have the opportunity to spread a lot of what we're doing across the country. When I was at Geisinger, we did a lot of the same kinds of work. I actually would like to start out by telling you a story about one of our patients, and that's Chuck. Chuck is 93 years old. He has had 6 hospitalizations for heart failure in the past year. He is legally blind and almost entirely deaf. He is not married, but he doesn't live alone. He lives with an 85-year-old woman who has an underlying behavioral health disorder. Stay tuned, and I will tell you throughout this talk what happens to Chuck. And if I forget, please remind me. So I want to just briefly tell you, this is going to be interesting, what we're going to talk about. And I'm going to try and spend as little time as I can on background about us, because I now know you have all the slides. I want to talk a little bit about new competitors in healthcare, some of the changes in the environment. Actually, I should ask you a question. Is there anybody who in your market has gone through a merger or an acquisition? Could you raise your hand if you've had any mergers or acquisitions? So just about every table. So we are in a dramatic transformation in this environment. We're going to try and make you experts in population health in 3 minutes. And then we'll start talking with you about programs that we've deployed in Massachusetts. And if there's time at the end, and there's a special slide at the very end, don't look right now, we'll see if you really have the right context for moving forward. So our reason for being, our mission, is we provide the right care with kindness and compassion every day for every person we serve. And our vision, our 100-year plan, is to transform care to improve lives. And I think you'll see how we're approaching our work and why we're so deeply committed to transformation. This is the moment for all of us to transform healthcare in the United States. And just a brief background, we've acquired a couple of groups since you've got that background information. We're now about 720,000 patients, about 1,300 clinicians, 900 docs, and one of the most special VNAs in the country. I know I can't help myself from bragging, and we're very, very fortunate to have a new CEO for the VNA Care, and that's Holly Chaffee. Many of you know her. Thank you for joining us, Holly. We have been a pioneer ACO since 2012, now NextGen. We have done successively better year after year from a financial perspective, and last year we had the top quality in the United States. And why are we different? We are committed to innovation. We have a separate innovation center. We are focused on ambulatory and home care. One of the innovations that has come out of this we'll talk about later today, which is care in place. Maybe a second would be a hospitalization at home program called ElevatingHOME. We were the first in Boston to do the first ambulatory total joint replacement. That is earlier this past year. We do partner with IBM Watson. We do partner with other developers of new products and programs. We'll talk a little bit about that. We have a very well-developed electronic medical record, which is Epic, and I know how you all feel about Epic as a home care EMR, so we won't go there. But we are very advanced, one of the first, if only, large ambulatory practices that's HIM 7's certified, and we are committed to academics to teaching the next generation of healthcare providers. You probably all know more about our VNA than I might, but we have a very, very special VNA. It is, in fact, the oldest in the country. It's about 130 years old, a not-for-profit, the largest in New England, with an average daily census of between 7,300 and 7,500, and about 1,800 FTEs. There are a number of subs in that VNA care, one that's based in Central Mass and one that's based in Eastern Mass, and of course our Hospice and Palliative Care program, our private duty nurse and home health program, which is VNA Care Advantage, and some interesting relationships with assisted living programs, and then an internal staffing agency. So one of the people who invited me said, why did you come together with a VNA Care? Why would a physician group come together with VNAs? And the answer is on this slide. We are the yin and yang in caring for patients and their families. We literally build relationships, programs, and better systems of care. And the solution for healthcare in the United States is to have a better system of care. We need integrated handoffs, tighter coordination, better protocols. We'll talk a little bit about that as we're going forward. Just earlier, I asked you how many are having mergers and acquisitions in your markets. I think that healthcare transformation is on fire, and it is unstoppable. In spite of all of the uncertainty about what's going on in Washington, we are in the midst of extraordinary transformation. Why do I say that? Well, we know on the tech side, there are literally billions, with a B, of dollars being poured into the technology side. We know there are interesting mergers and acquisitions underway. CVS and Aetna as an example. Where's that going? I didn't put the Amazon, Berkshire Hathaway, JP Morgan all together on this slide because I was originally thinking Amazon and supply chain. But what's that going to do? We see this explosion of urgent care centers all over the country. What's that going to do to primary care? The Fitbits, biometrics, all kinds of new data pouring into healthcare. How's that all going to work? Where's that all going to come together? I don't know. But I do know this, that we are in rapid transformation, and we can either wait and see what happens, or you can get in front of it. You can get in front of it. And the reason we merged with the VNA Care is we were trying to get in front of it. We had immediate alignment. We could complement each other. I'll show you some of the data in just a minute. For the VNA Care, it was a guaranteed referral source. We try and send more than 75% of our patients to our VNA, and it's a guaranteed source of referral. Everybody keeps talking about going to risk. I should tell you that 70+% of our revenue on the Atrius Health side comes from global capitation. So for those of you who don't know, that means we behave like an insurance company. We get all the money on a per member per month basis to take care of a population, no matter what happens to them. Whether they use the VNA, whether they are hospitalized, whether they're in a post-acute, for all their drugs, for all their labs, global cap. So we've been living in that value-based world for a long time. We entered the Medicare ACO in 2012 because we were in that space already. And we could work together with the VNA to do a much better job in driving new value, that is, lower costs and better outcomes for our patients. And we have. I think the Hospitalization at Home program, ElevatingHOME, is a beginning of a journey that will dramatically lower total cost of care across the country. And of course, together, we can leverage back office functions like our information technology, our care and case management program, utilization programs, and the like. So here's my transition to population health. I would say that population health became well recognized when we started talking about the triple aim, right? All of you know about the triple aim: better individual care, better care for a population, and better outcomes at a lower cost. The triple aim, it's now the quadruple aim: to reduce burnout, to have better experience for your staff. But population health is really the caring for a group of people, and more specifically, if they have a given condition, treating that condition and doing it well. So if you think about a population, any population, now this happens to be Medicare, generally there's a group of people who are healthy. That's the base of this pyramid. And for them, what we do is risk prevention and reduction. So eat well, don't get overweight, take preventive care of your bones, that sort of thing. That represents about 80% of most people in most populations. Then a portion of people get one chronic illness, maybe two. They're rising risk. They're people who had a screening study, they had a high blood pressure, and they get started on meds. That represents about 15% of the population. The remaining 5% of the population drives 50% of healthcare costs. That top 5% is where the major spend is in healthcare. And indeed, the very top percent, the very top 1%, drives about 23% of healthcare cost. So in the population health world, if you can manage the top 1% or the top 5%, you have a phenomenal ability to impact total medical expense. And if I slip and start talking TME, that's what I mean, total medical expense. Some of you might know it as total cost of care. And here are the dollars. These are pretty frightening to me. The mean expenditure for people in the top 5% is about $50,000. It's $47,498. That's the third bullet down. As compared to the bottom spend, which is, this is not a typo, $264. The top 1% is almost $70,000 a year per person. So if you can move the needle and lower total cost of care, you can really save a lot of money. Now, here's the takeaway. You should remember these 5 conditions. These 5 conditions drive most of total cost of care, total medical expense. And there's a test at the end to see if you remember what they are. So it's heart disease, it's cancer, it's trauma, mental health disorders or behavioral health disorders, and pulmonary. Now, I want to emphasize that they don't all come as a single entity. People have overlapping conditions. But behavioral health conditions drive up healthcare costs to a factor of 2 to 7 times. We've studied it, and we've proven that actually is the case. And you could envision that comorbid behavioral health would make it harder to treat your underlying medical conditions. Now, when we think about population health, we also think about populations as defined by who their payer is. So, and the patients in different payer classes have different conditions, believe it or not. So the Medicaid population has a higher incidence of asthma. The MA, which is Medicare Advantage or Medicare, has a higher incidence of cardiac conditions, heart failure, cardiac arrhythmias, and the like. And the commercial population has a higher incidence of cancer. The last 2 bits of information that I want to share with you, and now you will be experts in population health. At a cocktail party, somebody will say to you, what are the top 5 things that drive healthcare costs? And you're going to be able to say, never mind, I won't test you now, but top 1 is almost always cardiac. So if you think of the pyramid, top 5% driving 50% of the cost, top 1% driving about 23% of the cost, it is not always the case that people remain in the category that they've started in. So only about 38% of people remain in their category, in the top category, for 2 successive years. And how do we know that? And I'll just say, before I leave this slide, 11% of people, almost always, are in their last year of life, end of life. So I think I missed a slide or something to mention, and I will, well, I guess I won't find it, but that's no problem. These data come from the Medical Expenditure Panel Survey. That MEPS survey, which is published by AHRQ every year, is a very, very valuable source of information, of content information. And it has been going on for many, many years, and the themes are more or less constant. They have not changed. So those top 5 categories of conditions for population health have not changed. That's really important. So let me flip into the kinds of things that we've been doing in Massachusetts. So this is our care management model, Atrius Health's care management model. This is not necessarily the holy grail. This is just how we have done it. And what you'll see, and I know you have these slides, so I'm not going to force you to read every line in these small boxes. I apologize that the type is so small. But we tend to think of people and where they are and how we can tailor the interventions to what their needs are, keeping in mind people like Chuck, who is elderly, multiple conditions, hard of hearing, blind, not a great social environment, and recurrent hospitalizations. So we think of them in their home, we think of them in the emergency room, in a hospital, in a post-acute setting, and then how to get home again. And what are in these boxes are our interventions at each stage of the care management model. And what's in red are the programs that we have put together with the VNA Care. And so we'll talk you through some programs like Care in Place, which is the old-fashioned house call. And we'll talk to you about our total joint replacement program, our geriatric pharmacy program, just to give you a flavor of what's coming. Now, I've titled this slide Delivering. I was going to call it Deliverance. Depending upon how old you are, you'll know what the reference is. But these are what we actually do. So think about the conditions in population health: cardiac, cancer, trauma, behavioral health, pulmonary. And that's what we are doing, with some underlying emphasis on elective surgical procedures, which we have control over. One of the top 3 admissions to most hospitals are total joint replacements. So if you look at our interventions from a population health in the pre-acute space, before a hospitalization, we are working on telehealth, home telemonitoring, a diabetes prevention program. By the way, diabetes and obesity drive an awful lot of the conditions that we just talked about. And so if you can think about, those are medical emergencies, diabetes and obesity. If you can manage those, you can manage down total cost of care. When I was at Geisinger and we managed our diabetics, we could, after about 3 years, dramatically reduce the incidence of retinopathy, stroke, and cardiac conditions. So those are really important insights. So telemonitoring, our diabetes program, our heart failure program, our COPD program, do these sound familiar as it relates to population health? And then on the total medical expense side, we'll talk a little bit about the total joint replacement program, geriatric clinical pharmacy program. Mobile integrated health has been stalled because the regulations for the use of paramedics in the field in Massachusetts have not really been fully approved. We're very optimistic that will happen very shortly. Talk a little bit about palliative care. We'll talk about ElevatingHOME, and then the rest you'll be able to read on the slide. So this is just proof of our earliest hypothesis that if we came together with VNA Care, we could drive new volume to them. And what you can see in the colored part of the graph is certified on top and hospice on the bottom. And we came together in that first 2012, 2013, and you can see the steady increase in volume. You might wonder, well, why did it drop off in 2016? And that's because we were a larger group, and a portion of the group split off and went on their own, particularly in central Massachusetts. But even the following year, you can see our hospice volume begins to drive up. And I think you can actually see that. But what this gets us is tighter communication, next day visits, follow-up and better coordination with common protocols, and the opportunity to measure outcomes together. In the earliest days, this is an old slide from 2015, what you can see is that 30-day admits, 60-day admits, or these are readmissions and visits to the ED, all improved in the coordinated care with the VNA care. And what I can tell you is our VNA is spectacular in reducing rates of readmission. Readmission rates in Massachusetts, regrettably, are in that 15 to 20% range. Let me say that again, 15 to 20% readmit rates. If you go on our VNA home care service, it's cut almost in half to about 8%. And if you go on with telehealth, it drops in half to almost 4%. Let me show you the data. This is a little bit of a confusing slide, but what you're looking at in green and blue, these top two lines, they are your readmits without telehealth. And what's on the bottom in this magenta color is the readmit rates within 30 days. By the way, that's within a week, and that's 30 days. This is within 30 days. If you add, and that's in purple, I apologize, this is confusing. If you add and extend the telehealth beyond 30 days to 60 days, you can get your readmit rates down to almost zero. To almost zero. Now, what's happening in the space of telehealth is that there are now better biometric patches that are capable of monitoring much more material than ever before. When we talk about Medically Home, I'll talk a little bit about the patch that we're using, which I'll just in advance tell you is capable of measuring a single lead EKG, your pulse rate, your pulse oxygen rate, your body position, that is whether you're falling or standing or sitting. I would submit that that's a better set of measures than you get in almost any hospital outside an ICU in the United States. Total joints. There's an awful lot of total joints being put in this country, and that is going to continue based on the demographics of the population. What you can do in the context, by the way, this is one of the targeted conditions for Medicare in the bundle payment initiative. So hospitals are very interested in this. You can save money on the total joint side in any number of ways. You could reduce or avoid the post-acute stay, reduce the number of days in a SNF. You could reduce the number of days in the hospital. You could actually not do the surgery in a hospital and actually do it in an ambulatory surgery center and fully recover at home. And you could reduce the number of days of service from the VNA service providers. So those are all different interventions that you can work on to reduce total cost of care. The way that usually works, by the way, if you partner with a hospital, is there's some shared savings and you get a piece of that, or you should. So in our case, in roughly 1,000 patients, we reduced the SNF length of stay by 4 days. We reduced the number of patients going to a SNF by 12%. We reduced the length of stay on the VNA by about 8 days, and we saved a good deal of money, over $1 million. Care in place. This is a really fun and special program. In some regards, it's counterintuitive. It says that we will send a resource, a nurse or a nurse practitioner to your home. These are for people who are over 65 if you have a condition that we think is going to land you in the hospital. And part of the problem is that if you're over 80 and you have 2 or more chronic conditions, think of that population health, you know, the top 5%, think of Chuck, who has multiple comorbid conditions. You show up in the emergency room, and what's going to happen? You have more than a 50% likelihood that you are going to be admitted. And the more frail you are, you live alone, the more likely you are to be admitted. So if we can keep you in your home, we're much more likely to improve your care, and we're much more likely to save money. So if we just send a resource to your home in this Care in Place program, about 1/3 of the time you don't wind up going into the ED. We did this about 650 times last year. The majority of people who we intervened with were women over men. The average age was 82, and again, we saved about $1 million. So for not a lot of interventions, we can reduce total cost of care. As we kind of have been working in the space of home care and palliative care, you wind up missing what I would call the last mile. And that is, are there people who you could take out of a hospital and completely manage them at home? Well, I gave you an example of one population, which is elective orthopedic total joint replacement. We were the first in Massachusetts to do it. We do a significant portion of our total joints in the ambulatory setting and just send the patients directly home. But we were missing the medical admissions. So Medically Home is our bet to reduce between 15 and 20% of medical admissions that show up typically in an emergency room. These are people with cellulitis and asthma and COPD and heart failure. What are those? The top 5 conditions that drive the majority of costs. So Medically Home is our bet, and our model of Medically Home, which is sort of built off of a model that was developed at Hopkins by Bruce Leff, is really a 30-day episode of care divided up roughly into an acute phase and a restorative phase. And the acute phase is exactly that. That's where you have a lot of intervention. That's where you spend most of your money. But the restorative phase turns out to be equally powerful because you're developing a relationship with that patient and their family. You're developing an understanding, a deep understanding of their social determinants, a deep understanding of how they eat, their nutrition, the safety in their home, their risk of fall, and that's what happens in the restorative phase. Now, this is not just slap on a monitor, get all those biometrics. This requires a great deal of work. We have been at this for about a year and a half now. We have built a mission control center, which is duly staffed by a physician and the VNA care staff support. We have built a supply chain which must get to your home within 30 minutes, material that you need. So if you need something, you've got to be sure you can get the oxygen to the home. That turns out to be an extraordinary feat. It requires a change in mindset. You must get staff to that patient's home within 2 hours. That's kind of like the response time on most medical units. I say that advisedly. That's a joke. And you've got to have a staff that you have confidence in who can go in and do an assessment, start lines, start Foleys, administer drugs. We can get imaging into your house. We can get labs into your house. It is a really special program, and the people who have gone through it don't just say it was good, they say it was spectacular. Chuck, remember Chuck? Was our first patient. Chuck has not had a hospitalization in the last 8 months. Chuck is no longer in heart failure. Chuck is now living actually in an assisted living facility without his partner, who had a very serious behavioral health disorder that was impacting his medication adherence and his relationship with his family. So he's no longer in the top 5%. He moved out of that top 5%. He is no longer one of the 39% of people who stay in that top 5% year after year. We have had a major, major impact on Chuck. So you can move the needle in total medical expense. A word about our geriatric pharmacy consultation service. This is a brainchild of the VNA Care. They recognize that people who are on complex medical regimens, I know I'm out of time, I'll go really fast. People who are on complex medical regimens have high rates of readmission, and you can reduce, just by looking at the med profile, by half the number of hospitalizations. I think you all know about the importance of getting people to palliative care, so I won't spend any time on that. We have a targeted program for COPD. The way this works is these are not certified visits. These are visits that Atrius Health will reimburse the VNA for. We believe that by having that post-discharge visit by our VNA, that we can triage people to the right services and levels of care. We have just started this program. And a word about our analytics. We live off of a series of analytics. We can tell you the risk of somebody needing end-of-life care. We can tell you the risk that somebody is going to be admitted within the next 60 to 90 days. We can tell you what your risk of readmission is at the point of discharge. All those allow you to tailor your interventions of care and case management. So you don't have to cover everybody. You can just target those people who are at high risk. This is my last slide. I apologize for running over. I am very enthusiastic about this. This is a bird inside the mouth of a crocodile or an alligator. I'm not sure which is which. What's your first reaction about what is about to happen? You know the answer to this. Most people would say that that crocodile is about to have a lovely meal. But in truth, this is a true symbiotic relationship because this bird is actually cleaning the teeth, believe it or not, of this crocodile. And what the VNAs really can do is develop this symbiotic relationship with the healthcare delivery systems in this country to truly transform care and to truly improve medical outcomes and lower total medical expense. Thank you very much.
Well, I'm impressed. Anybody else? I think what strikes me personally the most is that of all of the things that we talk about in this industry, one of the things that we don't often talk about is the value that we get when professional collaboration is at the center of how we do quality care. And that the partnership between primary care physicians and home-based care teams is one that we are not fully optimizing yet, as clearly we have an amazing example of how when those two perspectives come together, the quality that comes out of that for the patients starts to break new ground. And so I want to introduce my co-presenters here and begin our transition from a discussion about quality, obviously a huge example for all of us to follow, and how does that bring us into the conversation about what research is. So before I get going, I want to introduce Ian Giuliano. He is the CEO of Excel Health Group, and Dr. Berna Demelrab, I've been practicing that, who is the Principal Research Associate with KNG Health Consulting. And I want to thank them both and acknowledge them as being the first of the partners that Elevating Home is working with to help move the needle forward in bringing research into the home-based care industry. So what am I even talking about? Well, there's lots of formal definitions of research, but this is my personal favorite. Research is formalized curiosity. It's poking and prying with a purpose. And on that note, I would really like to also acknowledge the teams at both Excel Health and KNG Consulting who are back in their home offices, but who have devoted a tremendous amount of time and energy and intellectual curiosity to help us poke and pry in this data and make the three of us look pretty good, hopefully. So when we talk about quality and research, we're really talking about a continuum. We look at quality in this country as really a comparative point. It's this idea of who's best, right? The old adage about getting out the ruler, that's really what we're doing. We are trying to say, what do we decide means excellent and who has the most of it? It is a comparative point. And the Atrius example talks to us about the standard uses of quality measures. He didn't spend much time on them, but look it up. Double 5 stars here, folks. And that in all of those standard measures that all of us work with in very public ways, they demonstrate excellence on those. They also explain to us today a whole host of internally developed quality programs and opportunities that they identified for themselves to demonstrate and measure excellence, all of which relates right back to the patients that they're taking care of. When we move that conversation into research, though, we kind of take a step backwards and we start to ask those questions in a larger format, because research is about developing new knowledge. It's that curiosity question that says, but why? You know, when you all had your 3-year-olds and wanted to just go home and cry some afternoons because all you heard is, but why? They're probably researchers in the making. What we are looking to do is take a systematic process to understand something and discover new knowledge that can then be used and generalized beyond just our own place. And the idea here is that by doing this, we as an industry can start to say, we have a voice in what is defining us. We have an opportunity to help shape those measures that eventually become the way other people define quality and home-based care. Those measures that get used on those public reporting sites, wouldn't it be nice if we were the ones helping to create those? So Elevating Home is working on doing that. We've had a small steering committee that met over a year ago and looked at the National Quality Agenda, otherwise known as the Quadruple Aims, and really said, yeah, that's us too. And started to look at opportunities where we could begin to engage in true research in each of these arenas And I'm very excited to say we are already doing it. We now have projects that are getting started in each of these domains, with more of them along the way. So please take a moment and read that really small print that you can read much easier in your app. But in the immediate, I am really excited to turn this over to Ian, who's going to start to talk about this particular project and our work on the value of home health.
Thank you. So first of all, thank you, Dr. Strongwater. That was fantastic. It's always nice to see real world applications and validation of what we see on a larger, more data-driven scale. It's always nice. Data is only half of the equation, though it's what's going on in the real world is the other half. Thank you to all of you for being here, and thank you to ElevatingHOME for partnering with us on this project, and thank you to KNG Health Consulting for all the work you've done. And I want to reiterate the thank you to the teams who have worked so hard on this project. So couldn't have done it without you. So a little bit about who we are and the data that we use. Excel Health is a data analytics company that in effect helps post-acute providers or enables them to thrive in this new era or paradigm of value-based care. KNG Health Consulting is a premier healthcare economics firm, and they were very instrumental in helping us design and implement this study. And everyone knows ElevatingHOME, and Danielle, thank you for all of your hard work in this. We couldn't have done it without you, so thank you. So to go forward, I press this button. Green button.
Top. On the top.
That right there, right? No? Oh, that one. Sorry. The little green button. There we go. So I should have figured that out. And that's probably the light right there that I was hitting. Hopefully I wasn't blinding anybody. So when we look at home health reimbursement today, we think about what is the rationale behind it, and is it an optimal strategy as we have today? And so what that leads to is it leads to, in what we've seen, when you see the structure of reimbursement today, and when you hear anecdotal conversations, have those conversations with some of the policymakers, you feel it's easy to come to the conclusion that today the focus of home health reimbursement is really just about reducing the cost of the episode and targeting fraud. It's hard to have a conversation with folks in Washington without them talking about home health fraud. Now, when you take a step back, though, there's several questions that you can ask about that. First of all, is this current strategy or approach to reimbursement, is it optimal for value-based care? And is it aligned with value-based care? Is it more specifically the optimal strategy for patients and taxpayers? And is the current strategy of viewing each modality in a vacuum, is that the right approach, or should we consider the impacts that one modality has on others or the entire continuum of care? And finally, if we take that approach and we see that there are different modalities that have positive or negative effects, those that have positive impacts, should they be emphasized and encouraged to grow, invested in, or not? So these are all great questions, and to answer some of these questions requires viewing home health a little bit differently, maybe through the eyes of an economist. The first thing an economist would think about is, wow, home health is relatively inexpensive and covers a long period of time versus other care settings. So right there, that hints to the economist that there could be some hidden values in home health beyond just what you see immediately. And the question they would then ask is, should we see home health as a driver of value in our healthcare system? Well, then the next question we would say is, well, how do we measure value? Right? And so when you have a care setting and somebody enters that care setting, one of the natural ways to measure value is to look at the delta, or the change in outcomes, right? The change in outcomes that are attributable to that setting, over or divided by the cost, but not just the cost of the episode, but the net cost. The net cost being the cost of the home health episode less any future cost savings. So that's pretty hard to do, right? You can't just take 20 years and randomly pick patients and say, you were supposed to get home health, don't get home health, and you were supposed to get home health, and we're going to follow you for a few years and try to figure it out. You know, that's not possible. However, as we were developing our product, we stumbled across a lot of really interesting observations that led to this study. The first one was the lack of adherence to home health instructions in America. We originally began to track how many patients were discharged from a traditional inpatient setting with instructions specifically to go into home health. That's box 17, discharge disposition on the claim. Hospitals are usually pretty good about filling it out. SNFs are not. SNFs are the worst at filling that stuff out. But so what we noticed was sometimes more than half of the patients at a hospital system told to get home health never actually got home health. So wow, that's a lot of patients. So we said, well, let's look at this nationally. And when we looked at it nationally last year, about 1.3 million patients were discharged from an inpatient setting with home health instructions. But only 800,000 of those 1.3 actually got home health. The other 500,000 did not. We said, wow, that's a lot of people not getting a relatively inexpensive care that covers a long period of time. So then I was talking with a hospital system, a more progressive one up in the Northeast, that took on a lot of risk. And I was talking with the chief medical officer and his team, and they were asking, could you help us predict those non-revenue generating or unprofitable hospital patients? This is the biggest fear of a hospital. Patient comes in, Medicare or whoever pays them for 3 days, but the patient's stuck in the hospital for 6 months. I said, sure, we can do something like that. It's going to take a while. That's a pretty complicated thing. But what about these more than 1,000 patients that were discharged from your system with home health instructions that never got it? That seems like pretty low-hanging fruit, right? So he paused and he said, okay, prove it to us. Show me that I should care about that. What's the difference in the 30-day readmit rate of those two patient populations? And he said, well, that's a very fair question. So then we began to track the 30-day readmit rates of every single hospital in America of those patients that were discharged from that hospital that had home health instructions. And the readmit rates for those that got their home health were very different than the readmit rates of those who did not get their home health. And as you'll see down here, in an example, this is an example of a large hospital system who will leave unnamed. You'll see that more than 50% of the patients told to get home health did not get home health. And you'll see that they were nearly 10 percentage points higher of readmit rate. So you had 13% being readmitted of those that adhered, and you had 23% being readmitted of those that did not. So we showed that to that chief medical officer, and he said, okay, I care. That's a fair point. So as we began to see this, we saw at hospital by hospital by hospital, every single time, the patients that did not get their home health that were supposed to had higher readmit rates. She said, well, there's a cost savings right there that's not being accounted for. All everyone is thinking about is the $4,000 or so average cost of a home health episode. The question is, what are some of the cost savings that we suspect are happening in the future via lower utilization? As an aside, they also noticed they owned a home health agency, and they also noticed that they weren't getting a lot of home health patients. And they kind of had a little, question for a moment. They're like, should we tell them they're losing all these patients? Let's move on. That's pretty much the way it worked. So this leads to the big question. So all of a sudden, we have all of these patients that were supposed to get home health but didn't, and those that were supposed to get home health and did. This allows us to ask a really good question. Is home health actually good for patients and taxpayers? Is it a good deal? Is it not a good deal for the patient? For the folks that are footing the bill? So to do that, we looked at, on a huge scale, we looked at the value of home health by looking at the differences in outcomes and Medicare costs between those two groups of patients. Again, outcomes is a delta change in what we took as mortality rates and readmit rates over the net cost, which is comparing the cost of the home health episode, about $4,000, to whatever money might be saved in the future, if any, from getting home health care. Okay? So a little bit about the study, and Berna's going to go into this in much more detail. She's the smart one here. So, but we looked at the study population. First we had to determine the study population. Obviously, they had to come out of a hospital. They had to be told to go into home health. We made some exclusions that we needed to make, and we divided those into 2 cohorts. Home health, no home health, or adhered to instructions, did not adhere to instructions. We then measured the outcomes. We looked at future costs, readmit rates, mortalities, and we began to do some analysis there, including some adjustments that needed to be made because those 2 populations, which Berna will get into in greater detail, those 2 populations are actually different. It's interesting. So, putting it graphically, this is what you see. Of those 1.3 million patients, once we made all of our exclusions, we distilled it down to about a little less than 500,000. We excluded things like those that had had home health previously, before going into the hospital, because it gets a little tough to determine, is this a new home health episode or is it a continuation of a previous home health episode? It's not always clear. So we'll move those aside. The patients that are really under 65 and are getting Medicare because of long-term disability, psych patients, cancer patients, etc., took all of those out, so we had a very clean population. But the good news is, almost 500,000 patients is a wonderful, very statistically significant population to deal with. And this is all possible now because of the incredible changes in big data and what CMS has done to make this data more accessible and available through various programs and partnerships. So, what's the first bit of news? Does home health have an impact on outcomes? Yes, it does. Congratulations. What you're doing actually matters. And not just during the episode, but over the 12 months after that discharge. What we found is that mortalities were lowered by 5 percentage points, which is pretty amazing when you think about it. It's amazing that one home health episode that lasts a maximum of 60 days, usually not, can actually, over the next 10 months, keep patients alive longer, more patients alive during that time period. The other thing that we noticed was the readmit rates were lowered by a full 10 percentage points over that whole year, right? So there's 2 things to say there. So when you look at the outcome section, the delta and outcome, yes, you've got a check, a positive check in that you are causing a change in the outcomes. 2 things that we want to say is, again, these numbers are unadjusted, and we'll get into that a little more. At a high level, suffice to say that the population that does not adhere to instructions is a higher severity. They are more acute. So you need to make some adjustments to make those populations more equal. That's number 1. Number 2 is there is variation by diagnostic category as well, and we'll get into those diagnostic categories in Berna's section, but this is the overall amount. So now to the cost. Well, congratulations. Home health actually costs a lot less than the $4,000. As a matter of fact, on an unadjusted basis, it's actually a net savings, because the cost of the home health episode, that $4,000, is actually less than future savings over the course of that year. It's almost like saying, I'm going to spend $4,000 and get a service, and wait, I'm going to get $5,000 back? What a deal, right? And so when you see data like this, and we'll get into some of the caveats to this, but when you see data like this, that suggests that this is a modality that should definitely be invested in, right? Does everyone follow that? So one of the things that we'll say, though, is that, and again, this means that home health is a driver of value. It's a driver of value, and it has a great ROI, or return on investment, for the taxpayer. These, again, are unadjusted results. Remember, that other group, that group that did not adhere, naturally consumes more health care than the adhering group because they have a higher acuity. When we make those adjustments, which we are in the process of doing, it's the hardest part of what we do, those figures will change, and probably some of those future cost savings will go down some. But the point being is that home health is a great value. If it costs more, if the cost of the home health episode is more than the future cost savings, it's not by much, and you still have that wonderful difference in outcomes. In some cases, it may still be that home health generates a true net savings. Either way, it's a fantastic story to tell to anyone who will listen, frankly, that a home health episode does not remotely cost $4,000 when you take the net effect, and you can provide demonstrable evidence that you're improving patients' lives. So I'll hand it over to Verna. We'll take it further.
Thank you.
Yep.
Thanks. Thank you, Danielle and Ian, for introducing our study, and thank you all for this opportunity to be here today. I'm delighted to be here to be presenting the results of our study. So, as Ian indicated, the purpose of our study is to assess the value of home health care by examining the differences between home health adherent and non-adherent patients in terms of patient outcomes and Medicare spending. To that end, we designed our study to address 3 research questions. 1, what's the experience of home health adherent and non-adherent patients in terms of readmissions, mortality, and Medicare spending? 2, do home health adherent and non-adherent patients differ in terms of demographics, socioeconomic, and clinical characteristics? And 3, after adjusting for patient differences, how do patient outcomes and Medicare spending differ between the 2 groups? We conducted our analyses to address questions number 1 and 2. So in today's presentation, we will present our results for questions number 1 and 2. Our analyses for question number 3 are currently in progress. We will touch on those analyses briefly, but we will not be presenting results on those today. So I want to start by introducing our study cohort a little bit. As Ian indicated, our study cohort consisted of over 466,000 patients who were discharged from an inpatient hospital between October 1st, 2015 and September 30th, 2016, with a referral to have home health upon discharge. About 71% of these patients received a home health visit within the first 7 days of discharge from the hospital. These are the patients that we're calling adherent, and they're going to be indicated in blue in our slides. The remaining 29% did not have a home health visit within the first 7 days of discharge, and that's the group that we're calling non-adherent, and they're going to be indicated with yellow in these slides. Our study cohort is composed of 7 groups of DRGs. Joint and cardiac groups were the largest, making up over 50% of our patient population. Respiratory and infections were the next largest, making up about 13 and 14% of the population. Next were digestive and renal, and skin and wounds was the smallest group, making up only 1% of our patient population. When we look at the distribution or the composition of DRGs, or the DRG composition within the 2 groups, adherent and non-adherent groups, we see that actually the 2 groups differ quite a bit in terms of their DRG distributions. For instance, among patients who are adherent to home health, more than a third of them, 37% of those patients, had a joint or musculoskeletal DRG. When we look at, on the other hand, when we look at the non-adherent group, only 19% of them had a joint or musculoskeletal DRG. The largest DRG group in the non-adherent was cardiac, making up over a quarter of that population. Cardiac was also the second largest in the adherent group. But when you look at these percentages, you see that the 2 groups vary in their DRG composition, and that's going to be an important factor, particularly that a good percentage of the adherent group consists of joint patients. That's going to be something I'll come back to. So let's now go into our first study question. What's the experience of home health adherent, non-adherent patients in terms of readmission, mortality, and Medicare payments? So basically, to address this question, we conducted descriptive analyses comparing the two groups, adherent and non-adherent, in terms of readmissions, mortality, Medicare spending, all measured over a one-year period starting with discharge from the inpatient hospital. So let's start with the mortality rate. When we looked at the mortality rate differences in our overall population, we saw that patients who are adherent to home health are on average have on average 5 percentage point lower mortality compared to patients who are non-adherent. That's over a one-year episode. When we looked at these mortality differences between the two groups across DRG categories, we observed two things. Number one, we saw that the overall mortality rates that we just saw actually masked quite a bit of variation across the DRG categories. When we look at these mortality rates separated by DRG groups, that we see that both the mortality levels as well as the differences between the two groups vary across the DRG groups. For example, we see a relatively large difference in mortality between adherent and non-adherent patients in the cardiac group. Among joint patients. So among joint patients, those who adhere to home health have about half the mortality rate as those who do not adhere to home health, although the mortality levels are quite low, around 2 and 4%. Among cardiac and skin and wounds, adherent patients have about 3 percentage point lower mortality. On the other hand, the differences in mortality are much smaller, in fact, statistically insignificant for digestive and respiratory groups. So that's the first observation, that there's quite a bit of variation in mortality rates and differences in mortality across DRGs. The second observation is that the 5 percentage point mortality difference that we saw in the overall population is partially driven by the fact that the adherent and non-adherent groups have different DRG distributions. So we do not observe really a 5 percentage point difference in any of these DRG groups, because what's happening in the overall population, what's driving that 5 percentage point partially in that overall population, is that a large portion of the adherent patients are joint DRGs, and the joint DRGs have really low mortality rates, around 2 and 4, driving the average mortality for the adherent group quite a bit down. So it's important, to look at these kinds of statistics overall, but also to dig a little deeper and look at variations across DRG groups. I'm sorry. For the 365-day readmission rate, I'm going to point you to the first columns over there on the left. What we saw is that in the overall population, there was a 10 percentage point difference between 365-day readmission rates between adherent and non-adherent patients. Again, when we look at that statistic, the readmission rates separately by DRG groups, again, we have the same observations. Number one, there is quite a bit of variation in readmission rates and the differences in readmission rates between the two groups across the DRGs. The largest differences are seen in the joint group, where home health patients have about 6 percentage point lower readmission rate, and as well as cardiac, we see a large difference there too, a 5 percentage point difference in mortality, with the adherent group having lower readmissions, having lower readmissions. The smallest difference in readmission rates is seen in the renal group, where adherent patients have a 1 percentage point lower readmissions compared to non-adherent patients. Again, the second observation is valid here too. The 10 percentage point difference in readmission rates we saw in the overall population is partially driven by the fact that the adherent group is composed of a large primarily composed of primarily joint DRGs that have a relatively low readmission rate that brings the average for that group down. Next, we look at Medicare payments over the one-year episode. And there, in the overall population, we see that adherent patients have about $4,300 lower average Medicare payments compared to non-adherent patients. That's over a one-year period starting with discharge from the inpatient hospital. Again, quite a bit of variation across the DRGs. The largest difference in Medicare payments are seen in the cardiac group, where the average Medicare payment for adherent patients is about $3,000 lower than non-adherent patients. For joint DRGs, we see that adherent patients have about $1,300 lower Medicare payments than non-adherent patients. And so for several of the DRG groups, such as digestive, renal, respiratory, we didn't see a statistically significant difference between adherent and non-adherent groups in terms of Medicare payments. So, as Ian indicated in his introduction, these are differences in outcomes that we're showing for our first research question are unadjusted. In other words, they're not adjusted for any differences in patient characteristics between adherent and non-adherent groups. Examining unadjusted differences between the two groups gives us a starting point, because when we start to do research, we first want to kind of see the lay of the land. What do things look like? But it's not an endpoint. It's not an endpoint because the adherent and non-adherent groups may differ with respect to a number of demographic or clinical characteristics that may be related to outcomes. And if they do differ with respect to these kinds of characteristics, some of the outcome differences that we see in the population could be due to differences in patient characteristics rather than the home health care received by the adherent group. Now, I should emphasize that, as Ian indicated, the two groups are similar in one important dimension, in that they're both referred they're both discharged with instructions to get home health upon discharge from inpatient hospital. Okay, so that's a very important distinction. But although they're similar in that one important factor, the two groups may still be different in terms of other clinical characteristics, various demographic characteristics. So that's what we want to investigate next, and that takes us to our second research question. How do these two groups differ with respect to patient demographic characteristics, socioeconomic characteristics, and clinical characteristics? When we compare the two populations in terms of patient demographics, we saw, excuse me, that on average, patients who are non-adherent are slightly older. They're also more likely to be male and more likely to be non-white. When we compare the two groups in terms of socioeconomic characteristics, we find that patients who are non-adherent are more likely to come from areas with low median income, with high poverty. We're not showing the poverty results here, but we examined those as well. And they're also more likely to come from areas with lower educational attainment. So what these results show us is that the two groups, adherent and non-adherent groups, are actually quite different in terms of patient demographics and socioeconomic characteristics. Next, we wanted to examine the two groups in terms of their clinical characteristics, and what we did is we looked at the patient's prior utilization 6 months prior to their inpatient hospitalization. We found that on average, adherent patients have fewer number of hospital visits and fewer number of ER visits and observation stays during the 6-month period prior to the inpatient hospitalization compared to non-adherent patients. Consistent with that finding, we also found that adherent patients have lower Medicare payments, lower Medicare payments over the 6-month period prior to their inpatient hospitalizations. So what these results suggest is that patients who are non-adherent are potentially more severe, and potentially more medically complex, and maybe have more comorbidities than patients who are adherent to home health care. So what that takes us is that if we see that the non-adherent group is more severe than the adherent group, when we see these demographic and socioeconomic differences, what that tells us is that some of the readmission mortality and Medicare payment differences that we saw under our research question 1 could be driven partially by these patient characteristics. What is needed then is risk adjustment of outcomes to control for these kinds of patient characteristics between adherent and non-adherent groups. That's precisely where we are in this study. We're currently conducting risk adjustments of outcomes, and given that non-adherent group is more severe than the adherent group, we expect our outcome differences between the two groups to potentially go down after we finish our risk adjustment in our research question 3. So I want to summarize our findings and wrap up my portion. So what did we find? Our descriptive analysis results show that relative to non-adherent patients, patients who are adherent to home health have lower mortality, lower readmission rate, and lower Medicare payments, all measured over a 1-year period starting from discharge from inpatient hospitalization. These differences may be partially due to differences in patient severity and medical complexity between the two groups. Therefore, it's important to conduct risk adjustment and to ensure that we control for such various patient clinical and demographic differences between the two groups, and examine what portion of the outcome differences actually remain after we control for these patient characteristics. So that's currently where we are, addressing question number 3. We're conducting risk adjustments and controlling for patient severity, medical complexity, demographic, socioeconomic characteristics may decrease the outcome differences between the two groups. So what does it all mean, and where do we go from here? I'm going to start that discussion, and then I'm going to turn it over to Danielle and Ian. So one thing that really has struck us, and strikes us every single day we work on this project, is that about 29% of patients who are referred for home health care upon discharge from inpatient hospital do not receive home health. That to us is a striking fact. As we dug more deeply into the data, we further found that these patients who are not adherent to home health or getting home health upon discharge are those that are on average more severe than the adherent patients. So the ones who are not getting home health are potentially, they have greater need for home health. So the big question that really lingers around the room is why? Why do people who seem to need home health the most and potentially benefit from it the most are not getting home health? We have a third statistic that really, is striking actually when you all put it together, that these non-adherent patients are also more likely to be minority, and they're also more likely to come from low income and low education and attainment areas. So all these statistics combined signal that there might be some barriers to obtaining home health here, where people who need home health are not able to access it. These barriers can be, there may be various barriers. These barriers may be financial or economic. They may be related to health literacy. It might be that the patients do not understand the value of home health. The barriers may be in terms of access. Maybe home health is not as accessible or to some patient populations or in some areas as it is elsewhere. So these are all very important questions that requires an answer. They're outside our current scope of they're outside the scope of our current study. Our current study is focused on understanding the value of home health. But again, a very related question, which I'd like to bring up, is that that we need to understand why patients who potentially have greater need for home health not getting it. Are there barriers to receiving home health? And how can we overcome those barriers? These are all questions that need to be addressed to ensure that people who benefit from home health are able to access it. So at this point, I'm going to turn it over to Danielle.
Thank you.
Okay. Thank you.
Implications of this work just keep going. So in addition to the many hours of debate that we've had around this issue of why people don't get home care, and I would add in a few more structural barriers. We don't actually know, was the patient even told to get home care? Did a home care agency receive a phone call or a fax or any communication? Was there a smoke signal about this patient? We have absolutely no idea what's happening between the point where the claims record has a checkbox and the actual patient. I would push that further into the clinical care realm and start to really ask a lot of questions about what is this patient acuity issue. Acuity is that nurse word we talk about a lot. We've referred to it here in regards to severity, and we have some hints around what that could mean to us. But when we start to dig deeper into what are these DRGs, it comes back to some of the points that Dr. Strongwater was making. We're talking about clusters of DRGs because that's the way home care we think about patients. But when you dig down deeper into an individual DRG within the group, we see even more differences that really point us in this direction of severity and issues of acuity. And it leads us into questions about how do we provide the best value for specific types of patients, and how do we continue to fine-tune the work that we're doing to be really specific to what the patient needs are. This type of work also gives us an opportunity to create some baselines, right? We work with our Home Health Compare and all of the data that we do as a regulatory component, and that brings us back to that quality part where we have these measures to compare ourselves on. Well, this information also gives us some measures, but what it's giving us is an average. So when we look at an average readmission rate, there are patients who are on both ends of that spectrum, right? If you think about what the average is. So it gives us an opportunity to then look around and say, where are the patients? What types of patients? Is it a patient type or an agency type or a geography or a hospital type that is actually doing better than that average on those quality outcomes? Where do we have the least mortality, the least readmissions? What can we learn from those patient populations? And how do we take that information back to our agencies to turn that into actionable work and be able to say, I'm learning something about how to provide care to the people I'm working with that will continue to decrease their risks and continue to improve their ability to stay home. This is really the act of finding those best practices that we talk about on all of the committee calls that we work with. This type of research helps us to give a grounding in our best practices in something that we can also then translate into policy conversations and discussions with our hospitals and our payer groups and continue that loop all the way through. In general, what my focus on this, and it's so interesting to work in an interdisciplinary group because we all come at this from a very different side. And I really want to figure out what do we do to continue to improve the top of the equation, those outcomes. Where are those best practices? What does it mean? Who are the patients? What are the structures? What are the types of criteria that give us the hint about how we provide better and better care? I'm going to stop talking and let Ian talk more about the bottom of the equation and that net cost issue.
Yeah, and I'll say that in the one thing that bears note, remember that DRG slide that showed the total cost by the various DRGs? Remember that the blue, the adhering, actually included the home health episode. The yellow did not. So when they look like they're on parity, or that the blue is slightly lower than the yellow, remember that the blue has that added cost of home health included. Does that make sense? So going over to the policy implications of this, we feel unequivocally from this study that home health care is a modality that delivers value, and that it has a very positive story that needs to be told. And instead of viewing home health as a cost that needs to be driven down further and view it in isolation, rather view it as something of, hey, home health actually can play a role in helping to bend the cost curve nationally and is actually a modality that needs to be invested in further. And that's what's so gratifying to see some of the stuff you all are doing, because it proves it out. But the one thing that I'll say is every shortcoming is also an opportunity, and you all have a giant opportunity to invest more in research at the policy level. As an industry, I feel that you all, frankly, are falling pretty far short of the mark. And if you do not do this type of research, and you do not, as an industry, invest in this type of research, you're not going to have much of a voice. So what I would encourage you all to do is a few things, is just humbly, as from an outsider looking at this, is realize that you play a greater role in the entire continuum of care than you think. And it needs to be, as hospitals and hospital systems inevitably move down the road of assuming more and more risk, you all, if you communicate, if we're able to communicate the value you bring, should be viewed as a key partner, as Atrius has done with VNA. So there is that. And also, you all have to be proactive and vocal, not only in your partnerships at the system level, but how you're viewed on a national level, and how you're viewed by the policy makers and those that are determining how to approach reimbursement for home health. That's it.
I think we have a couple minutes for questions. I'm sorry, I don't have a clock in front of me. Are we okay time-wise?
10 minutes.
10 minutes. Okay.
Yep.
So just to conclude, I think that our hope here from this conversation was really we're trying to illuminate this whole spectrum of quality and research that we have in home-based care, and hopefully garner your interest in both sharing your actual work and the stories and the role models and the innovations that you are doing in your own agencies that are really driving quality in your local space, as well as help to make this connection between what you're doing and how we can do more formalized research and more formalized systematic investigation that gives us some underlying information into the whys and allows us an opportunity to keep sharing that work and growing those innovations and positive efforts. So I'm hoping that there's a member of my team out there with a microphone, because I do see people with hands up. And I'm not seeing a microphone, so I'm going to ask maybe if you could...
speak.
Oh, do we have microphones? Thank you.
for quite a few years, and it's amazing, 30 years ago, trying to find a workforce that would go into high poverty, high crime areas was extremely challenging, and I think it's only gotten worse. So hopefully, through the research, and you've honed in on the access and compliance from a patient perspective, but looking at the crime elements in those zip codes and trying to find a workforce that will go into those. So it is access, but it's not because not necessarily there aren't home health agencies that cover those areas, but they don't have the workforce that will provide the care that needs to be provided in those areas. So
thank you. I'll have an envelope for you at the end of the meeting, because you just hit on a couple really critical things. One is that we just don't know. It is a regular part of our work conversation to remind each other that we can't, in a research process, jump to conclusions. We have to continuously challenge ourselves about the why. And so your point about the why of this issue of zip codes and socioeconomics is critically important to make sure that the research stays as unbiased as possible. I would also really thank you for the nod to the workforce issue. That is a huge and growing conversation, and it comes back to issues of clinical care and how do we manage acuity and how are we prepared for that and how do we make sure that we can give the patients everything that they need in their home-based space. So thank you for both of those.
And I would say as an add-on, again, going back to the policy implications, common sense would dictate that the sort of the one-size-fits-all structure today may not be the best. If you really want to, bend the cost curve, you have to incent people to provide care in those more difficult areas on weekends, on holidays, things like that. And so if we had the ear of policymakers right now, we would ask them to consider being more flexible and creative in some of their reimbursement structures to address these type of issues that you raise.
Is it on? Okay. Two questions. One is on the non-adherent patient population. Are you clear on if the patient is non-adherent because they chose to be non-adherent or because the agency didn't admit them? Because those are two very different things.
Right. At its most basic, we can't even be entirely sure that these patients were technically eligible.
Right, eligibility being the big thing, like did they really qualify, were they, homebound?
And that's one of the challenges, and we always have to be attentive when bringing out research. There's always going to be limitations. Mm-hmm. In this particular case, we have to work with the data that exists, which is the hospital discharge form. So that's all we can say about what we know on how we've identified these groups.
Okay.
I will add that when we first started showing this, putting this out to the home health industry, it was very interesting because the home health would say, well, those are patient refusals or NTUCs, the patient didn't qualify. Then you go and after you hear your fourth or fifth hospital CEO look you right in the eye and go, I don't know how many of our patients got their discharge instructions, or I don't know how many were coherent when they got their discharge instructions, or even if you could find a discharge planner that'll work on the weekends here, by all means, send them our way because we don't have anybody. You start to say, I'm getting the sense that there's some real shortcomings in the system. And I think a big opportunity for home health agencies is to take this data, show the numbers of patients that aren't adhering, show the readmit rate differences, and say there is an opportunity to move the overall readmit needle for this hospital system if we could look at the process and make it better. I don't think patients are getting their instructions. I don't think their family is getting their instructions. And more importantly, I don't think it's adequately being communicated to the patient or the family what the instructions, what the care involves, and what are the historical ramifications of not getting that care. I believe if you tell patients, hey, by the way, if you don't get that care, you have this much percentage more likely to be readmitted. You want to come back in 30 days, be our guest, don't get the care, the hospital will make more money and I think a lot of those, looking at that and getting the physicians, I think, more involved too sometimes could make a big difference in that adherence rate.
right. And my second question was about the severity or the acuity. I understand y'all are saying you're just now getting to really delving into that. Y'all kind of made some general statements that the patients are, the ones that are non-adherent, are more severe. How much have you confirmed that? I mean, have you looked at diagnoses yet? How are you measuring acuity and severity in that non-adherent group? Or are you just getting to that? I wasn't clear on that.
Yeah, that's right. So we're currently conducting those analyses, so I'm kind of hesitant to give results because we're in the middle of the analyses. What we're using definitely the primary diagnosis in the inpatient hospital. We're looking at the comorbidities the patient has. Those are some of our primary control variables. We control for ICU days in the index hospital. So we primarily get indicators from that inpatient stay to measure acuity, if you will.
And we look at prior. I mean, two of the other things. Right. Very simple. We look at total prior year spend. So how much did patient A consume in healthcare resources and cost in the prior 12 months versus patient B? That's number one. And then, as Berna alluded to, we have a weighted score for hospital utilization. So how much and what type of hospital utilization or hospital services did they consume in that prior year? It's actually that combined with the information that Berna talks about gives you a pretty darn good sense of acuity.
And we will let you know when we have results we feel comfortable sharing.
I do want to make one point about your first question too. So in other research, we look, we examine value for other post-acute care settings as well. Like we've looked at long-term care hospitals and SNFs and IRFs. So when you compare, discharge instructions, what's on the discharge status coming from the hospital, and then look at the claim and see what actually the patient got, there's always some mismatch. All right, so but for these other settings, I'd say, don't quote me on this, but there might be 1%, 2% mismatch, okay? Where the hospital discharge instruction will say one setting and then the patient ends up going elsewhere. Yeah. The 29% is huge. So that's really, so although there might be cases in there where the patient was not, potentially eligible for home health, we really don't think the majority of that is driven by kind of patient not being eligible or
correct
or something.
Correct.
Like
and when we looked at it, we were very surprised. We were so surprised. We said it can't be possible if these many patients aren't getting their care. They must be going somewhere else. They're not. We thought they were going to SNFs, but then we looked, and a very small portion of them they're not getting anything. So you got to think that if it was a wholesale issue of not qualifying for home health, at least some portion of them would be routed into some other modality. Not true. They're just not getting any care.
Tracy.
From the audience, and I also want to note that for the folks who are listening and watching by the live stream, we will respond directly to you with your questions after the fact. Here's our first of the last two.
Yes, I was wondering if you looked at the geographic clusters of adherence versus non-adherence. For instance, different states. Do you have better performing states? And also looking at rural versus urban versus dense population center, because we all have a feel for what probably is happening or not happening, but do you have the data around that? Thank you.
So I'm just going to jump in and say, yay, a room full of researchers. We don't have it yet. Those are things that are on this potential list. We do have to have a limit to this study, as much as I would like them to do this all the time. There will have to be an endpoint, but those are all really important questions, and they are certainly things that if we can't get to in this one, need to be included in future work.
And I will also say that we did, and Danielle doesn't know this, but we did look at adherence by states previous to this study. We have published some stuff and put it out. If anyone's interested, stop by our booth and we'll be happy to send it to you. I'm struggling to remember which was the best state. I feel like it might have been, it was a New England, was it Vermont or something like that? It was a New England state.
Massachusetts.
There you go. Western Massachusetts by far had the best. Anyway, but we do have some data on that.
And we did some preliminary work, I don't know if this addresses your question, but preliminary work where we looked at hospital characteristics, how they differ between adherent and non-adherent groups. And we saw that the non-adherent groups are more likely to be the ones to be hospitalized in kind of major teaching hospitals, large hospitals in urban areas, and that's kind of consistent that these kinds of hospitals are more likely to be located perhaps in center cities where there might be lower income and lower educational attainment. So that's kind of consistent with our socioeconomic findings as well.
I think we have one last.
First of all, I would like to thank you for this very important discussion and this research. Frankly, I don't know another venue in home care where you can get this quality at an association presentation, and I could only hope to say that every provider agrees to bring somebody next year, because this dialogue is so important, and it's why we at Joint Commission are so heck bent on this interdisciplinary. That said, I just want to say the mark of good research is that it spawns more questions, and you certainly have done that for us this morning. I would just like to also say one of the things that Dr. Mark Chasson always tells us is that unfortunately facts and deltas such as this don't often change people's minds. It's a belief thing. So what I would really like to see happen, because there's no shortage of studies done by hospitals and health systems and think tanks there that talk about discharging patients. I would love to see some future work done to triangulate the work and the research coming out of their tank with similar research from our industry, and then take a step back and upstream to the stakeholders, the people that are making those decisions, to say, why did you believe that despite all of this was the right choice? And I think that's when we begin to get underneath the factors that move leadership and start to communicate the importance of really interdisciplinary communication and transitions of care to achieve better outcomes in a sustainable fashion that really gets us to the point of zero harm.
Thank you so much, Marlene.
Thank you.
I can't top that. So, I'm getting waves that we have questions. I will say that if those of you who need to take a break or stretch your legs, please feel free. If you want to continue questions, I'm going to just answer for all of us. We're okay to stay. So yeah. I think, Dr. Rosati, you have the microphone.
So actually, a lot of my questions have been answered, but I do have one more. But I wanted to make a comment. There's actually a third group in here that you can study. That's those people who they didn't check off in the discharge planning but went to home care. So I think it's interesting because to find out what that group is like as well. The point I wanted to make, and I wanted to ask you a question about this, is on that non-adherent group, how many of them were getting rehospitalized within 24 to 48 hours? Because that could drive the rate up.
We excluded.
So that was my question.
What's the question? On that non-adherent group, how many were readmitted within 24 or 48 hours? I believe we excluded those. If they were readmitted prior to having the opportunity to receive home health, we excluded them from the study. But it was a very short time period because obviously if the home health agency or the hospital delays in getting them the home health, well, that is something that you'd want to take into account. And to answer your question on the first question, we do track today in our portal the number of patients that get home health within 30 days of inpatient discharge without home health instructions. And surprisingly, it's about another 50% increase. So if you had 1,000 patients that got instructions to get home health, you'll have 500 of them adhere. The other 500 just went off into space. And then you have another 500 patients that never had home health instructions and ended up getting home health. And we point that out to the hospitals to say, what's going on here? Are you letting home health, and even worse, it happens in hospice too, hospice-appropriate patients walk out your door without the care? And it does resonate. In this new era of value-based care and hospital systems assuming more risk, it is an argument that definitely, and a data point that really resonates with the hospitals. Because the point being is, if you caught 500 of them, how many of them didn't you catch? And probably a lot more than the 500. And then what happened to those patients? You probably got to see them again.
Go ahead. I have one question. Can I get the marketplace data that I'm in so that I can drive it from you?
Of course. Absolutely.
That's all I want. Thank you.
We'll introduce you, Faith. Any last? Okay. I really want to thank everyone for your interest and your attention, and I am so excited that you are interested in this work. Please do share your ideas and your curiosities and your questions, because they will lead us in how we develop our next projects and groups. And please pay attention to our website, because I will be looking for volunteers and participants for some of the studies we're organizing now. So you can be involved. Thank you all very much.
Thank you.